Good afternoon, everyone. Thank you for joining me today. It is Friday afternoon, so we'll make it quick and easy, and you absorb some information about fatty liver and alcohol use this afternoon. My name is Millie A. I'm a nurse practitioner at Tufts Medical Center in Boston. Today, we'll be diving into an important and evolving area of hepatology. It is metabolic dysfunction associated steatotic liver disease. We call it MASLD. And metabolic dysfunction with alcohol-related liver disease. In short, now they call it MetALD. Is it important for us as a provider to see fatty liver and alcohol-related patient in our daily clinic? Fatty liver happens to be so important topic for the liver. Alcohol is a major cause. It damages the liver cells and increase fat storage. Over time, this can lead to serious conditions like hepatitis, cirrhosis, and even like liver cancer. So limiting alcohol is key to preventing liver disease.
Millie, sorry, we don't see the slides advancing on the screen.
Oh, okay.
We just see the title slide right now.
Let me see.
All right, yep, there it's advancing.
Okay, sorry about that. But just this chance to get this QR code to record your attendance for this meeting. So if we are all ready, this is our case today. This is Ashley, 52 years old woman. She was referred after an abdominal ultrasound, showed mild hepatomegaly and increased echogenicity consistent with steatosis. Interestingly, she feels well and has no complaints. The case will serve as our anchor as we go along with this PowerPoint, as we walk through MASLD and MetALD today. So let's review some of Ashley's background. So she has history of PCOS, hypertension, and hyperlipidemia. For the medication, she is on antihypertensive medication, amlodipine, atorvastatin, multivitamins, and miltazol. For the physical exam, mostly unremarkable. We, as a clinical practice, we don't quite feel the liver, but she's otherwise asymptomatic. She's typical of many patients with fatty liver disease. So here are her labs. Vitals are 140/78, BMI 29, ALT, AST mildly above upper limit of normal, 46/55. Platelet normal, A1C 5.9, pre-diabetic, triglyceride 185. So this is her FibroScan result. So as you can see, she falls into this significant fibrosis category with 11.4 kPa, and her steatotic score is 310, which falls into severe steatosis category S3. So to digest a little bit, she does have fatty liver. Not only that fatty liver, the liver, you can see some advanced scarring as evidenced by the high kPa. So here are some education piece for us. So here's the broader framework under the umbrella of steatotic liver disease. We have multiple categories. If you look at the navy blue on the leftmost is the MASLD, metabolic dysfunction associated. And if you look at the rightmost for the blue, is alcohol related. So today we are talking about something in between, the dual etiology, MetALD, metabolic ALD, alcoholic liver disease. Where metabolic dysfunction and alcohol overlap, there are also less common causes, which is in the gray boxes of this slide: monogenic disorders, drug-induced injury, and others. So I love this slide. I think this slide can serve an reference for our daily visit, even you're not at the not working at the hepatology. So it is important to understand alcohol equivalence. A standard drink in the United States contains about 14 grams of alcohol. So for women, moderate to excessive use is defined as 140 to 350 grams per week, which is about 10 drinks or 10 to 20 drinks per week. And for men, 210 to 420 grams per week, it's basically 20 drinks per week. This becomes clinically relevant when we assess MetALD. So this slide highlights key mechanism. Both metabolic dysfunction and alcohol contribute to steatosis, meaning fatty liver, and steatohepatitis, the inflammation caused by the fat in the liver, or you can say from the sugar from the alcohol, and progression to cirrhosis. They drive disease through overlapping pathways, such as oxidative stress, mitochondrial dysfunction, and inflammation. So I like this diagram. It is the drivers of liver disease. Sometimes you see these patients, should you, in the back of your mind, should you worry about them? So let's look at this graph. If you don't mind, turn your attention into the middle part of the slide, the dynamic spectrum of SLD, steatotic liver disease. So for the MASLD, MetALD, and ALD, if you look above, we are measuring the risk for decompensation, liver decompensation. So for only fat in the liver, if on the left axis, you see the fibrosis score. If you diagnose with MASLD, fatty liver only, with no significant fibrosis, the risk of developing decompensation is just less than 1% in 5 years. Versus if you are having fatty liver disease and when you diagnose, you have significant fibrosis, F3, F4, 5-year risk increased 15-fold to 5 to 15%. This is not the worst. If you look at the graph towards to the right side, ALD, so entirely from alcohol. So for alcohol, if you drink more than you used to with that guideline, 10 drinks for women, 20 drinks for men. When you have alcohol in your system and you come to your hepatology office, find out you have no significant fibrosis, the 5-year risk to develop decompensation, 2 to 15%. I mean, it is not very high, but it is already highest, just like those people get fatty liver only. If you happen to get diagnosed with your alcohol liver disease and your fibrosis score is significant, your 5-year risk of developing decompensation increased to 15 to 50%. So half of those patients who get alcoholic liver disease and diagnosed when they were diagnosed as F3, F4, you have half the chance you end up with the liver decompensation, such as ascites and encephalopathy thereafter. So what if, just like our patient, what if you are something in the middle? So your risk is not as high as those people who get alcoholic liver disease, but it's not as low as those people who only have fat in the liver. So if you look below the bar for dynamic spectrum of SLD, cardiometabolic risks include obesity, insulin resistance, type 2 diabetes, dyslipidemia, and hypertension. Some genetic factor make you easier to deposit fat in your liver and your internal organ are these genes. And if you increase the alcohol more than you should be, your risk of developing decompensation also increased in falls. So here are some detection of alcohol use with biomarkers. Of course, you can do a questionnaire. You can get some sample. You can evaluate how much alcohol the patient consume. Also, you want to evaluate whether the patient has a risk factor to develop fatty liver disease, including do they have underlying metabolic syndrome such as type 2 diabetes, what was their diet, look at their BMI and their lifestyle. But on this slide, I want to stress that when alcohol history is unclear, biomarkers can help. PEth and some urine testing, blood testing such as MCV, GGT, CDT, and the alcoholic non-alcoholic index all have their utility. PEth, if you remember one thing, PEth is a particularly valuable test. It is highly specific and detects alcohol use for up to 2 weeks. Interestingly, about more than a quarter of patients who are diagnosed with fatty liver disease, they actually happen to drink more than they should be. So here we see the challenges. MASLD, which is the fatty liver disease, assumes the etiology is from fat. ALD assumes the etiology is from alcohol. So here's the gray area that MetALD exists in the gray zone. This is why we incorporating alcohol biomarkers. It's important to avoid misclassification. So here comes our patient. So this is our patient. Her alcohol consumption, we did blood test for her, and PEth happened to be 120. So interestingly, in the clinic, if you happen to hear patients say, you ask how much alcohol do you drink? Maybe one drink a week. They're probably 5 drinks a week. So moderate to heavy alcohol consumption. So here's the so PEth is detectable for 3 to 12 days after a single binge and is not affected by sex or BMI. It is increasingly recommended to complement patient history in both clinical care and research. So this is a research alcohol use in individual with excess weight. This was published in 2025. More than 600 patients screened for the study. Eventually, 617 enrolled. We exclude those viral hepatitis or other etiology of liver disease. Eventually, we get a number of 333. Among them, 97 of them analyzed with suspected MetALD. So it is not a rare population. It's actually about 15% the risk for MetALD. In clinical, we usually want to categorize patients either fatty liver or majority alcohol. But indeed, 15% of those patients that you categorize either side, 15% of them is actually a combination. So our patient does have metabolic syndrome, PCOS, hypertension, and hyperlipidemia. So I want to point out this alcohol has a biphasic effect on blood pressure. Initially, it lowers blood pressure for about 12 hours, but then increases after 13 hours. This explains why patients with chronic use often present with hyperpressure. alcohol and triglyceride. Alcohol also acutely raises triglycerides. This further compounds metabolic dysfunction and contributes to fatty liver. So circling back to our case, she drinks about 2 glasses of wine daily with her metabolic risk factors, her FibroScan and her PEth of 120. Her diagnosis is MASLD, predominant MetALD. This is a very smart sentence to categorize this assuming fatty liver disease patient, but this gives your follow-up, or someone will help you to follow up this patient more easy to follow, because she has, according to this sentence, MASLD, predominant MetALD. Your next follow-up will be to assess if she improved or maximized her control of her metabolic syndromes, and you want to check out the alcohol use. So with that, this brings up critical management questions. So what treatments are available? So like our fatty liver patient, diet, exercise, and weight loss of 10% will be the goal. And with the diagnosis of severe fatty liver and advanced fibrosis F3 or F2, she's a candidate for a medication called Resmetirom. Resmetirom is a medication can reverse the scarring of the liver and reduce the steatosis. What are your recommendations regarding the alcohol use? Hey guys, patients should stop drinking the alcohol completely. Does she need HCC screening? The answer is yes. Given her advanced fibrosis F3, when she diagnosed with liver disease, she should have HCC screening. Initially, every 6 months, as she get better, we can have a deal of once a year as long as she doesn't demonstrate continuous advanced fibrosis. If she does, we treat her like she's having cirrhosis with every 6 months HCC screening. So there's some ideal MetALD definition for clinical trials based on objective biomarkers. This can overcome underreport of alcohol use and standardize the assessment of recent alcohol use, because like PEth assess the alcohol use up to 12 weeks to certify alcohol abstinence. Second, it can ensure that drivers of liver disease are present. Consider more than one cardiometabolic risk factor, or ensure the persistence of hypertension and hyperlipidemia after stop alcohol use. And consider exposure to risk factors, fulfillment of criteria during the last 6 to 12 months. So what's the take-home message for today? Alcohol intake beyond 140 gram for women, basically, if you calculate 14 grams of alcohol a day is the 1 drinks, about 10 drinks for women per week, and 20 drinks for men per week will be more than beyond the alcohol use that you want to categorize into your liver disease. And clinical criteria could underestimate MetALD. We can use alcohol biomarkers. I actually incorporate that in my chronic liver disease workup. So patient gets scanned for their PEth. And ensure that drivers of liver disease are present. You want to mention that in your note that the patient has metabolic dysfunctions such as diabetes, prediabetes, hypertension, hyperlipidemia, OSA, PCOS. and consider adequate exposure to risk factors and allowing comparison among different social cultural realities. And there are more disease stage education you can find under the GAP, MASLD, and MASH. And that's about it. You can screen this QR code for a short survey, and you can tell us what other topics you want to listen more about. And I am ready for some questions.